My name is Zaamin Hussain. I'm presenting from Emory University. Incision or Excision, what to do with the A1 pulley for trigger finger, results of a multi-surgeon randomized control trial. Thank you to my co-authors, obviously without whom this project would not have been possible. Our disclosures can be found on the Academy website. So as most of you all remember, there are 5 trigger finger pulleys in the flexors that facilitate flexion. When the A1 pulley is thickened, it can prevent smooth tendon gliding. This results in triggering of the finger. And when looking at this a little bit more closely, most surgeons incise the A1 pulley. However, there's recently been emergence of the idea of excision of the A1 pulley. Incision is making a longitudinal incision on the A1 pulley to release the flexor tendon. Excision is complete resection of the A1 pulley from the insertion on the metacarpal and the surrounding capsule. The problem with incision is that it results in around 3% of recurrence, and this risk is higher with patients who have diabetes mellitus as well as hypothyroidism, and this results in more use of corticosteroid injections, more occupational therapy visits, and ultimately results in about a 1% reoperation rate. Excision the thought process is that it could reduce scar formation and therefore reduce recurrence. So we wanted to test this, and the purpose of our study was to assess the impact of excision on pain, recurrence, and activities of daily living. And we hypothesized that we could reduce the pain, reduce recurrence, as well as have no impact on activities of daily living. So we performed a prospective randomized clinical trial that was single-blinded to the patient only. It was a 2-arm study, Incision and Excision. We included patients that were diagnosed clinically, that had failed non-operative management. These were consecutive patients performed throughout 2023. It was performed by 5 upper extremity trained surgeons, and these were adults only. We excluded patients that had had previous releases of the digit of interest. Our primary outcome was the VAS pain score, and our secondary outcomes were multiple patient-reported outcome measures as well as the risk of recurrence. And these were all taken at 2 weeks, 6 weeks, 3 months, 6 months, and 1 year. The study was powered on VAS pain, and this resulted in needing 30 patients per group for 80% power. Students' t-test was performed for continuous variables, chi-squared for categorical, and Bonferroni correction for multiple statistical tests. We included 124 patients met the inclusion criteria, and 80 of those actually got enrolled. 41 patients to Incision and 39 to Excision. 1 patient withdrew in each group, resulting in 40 patients being analyzed in the Incision group and 38 being analyzed in the Excision group. Overall demographics were very similar between the 2 groups. Notable differences that were non-significant were there were slightly more smokers in the Incision group and slightly more diabetics in the Excision group. In terms of the digits involved, there were slightly more central digits than peripheral digits and more right hands than left hands in the Incision group. Now, looking at the results, because this is a randomized prospective study, as you would expect, the preoperative data was very similar between the 2 groups. At 6 months post-op, the results were also very similar, except pain with pressure. There was actually slightly higher in patients who had had excision. In terms of the VAS pain scores, these were also very similar, non-significant differences pre-op as well as going all the way to 6 months. However, there were differences in complications. Incision, 1 patient had severe pain and stiffness that required a corticosteroid injection. 1 patient had a skin glue reaction that required just observation. However, patients who had Excision, 1 developed flexor tenosynovitis and 1 developed wound dehiscence. Both have required reoperation with an irrigation and debridement. There was 1 patient who had a recurrence in each group. The study is limited, the fact that it's powered by the primary endpoint only, and long-term follow-up is still pending. In conclusion, the results are very similar between both groups at 6 months. Incision is associated with a reduction in pain with pressure. Excising the pulley may actually increase the complication rate, and excision may not be the solution that we are looking for to avoid recurrence. Thank you again to my co-authors, and thanks for the opportunity.